My name is Leah Rosengass. I'm with Copal Solutions. We're a consultancy that's based out of LA and New York. Some of you may have met Howard Springer in an earlier session. I won't spend too much time talking about our firm, except to say that our goal and our mission as a firm is really to help our partners, which are typically large health systems and the delivery system, to make this transition from volume to value, to really embrace population health management and then implement those solutions. Okay. So we have a lot of expertise in 1115 Medicaid waiver in multiple states. So that's why I'm here to help bring that perspective. And it sounds like we've got a presentation in the room, and then we'll tag team on some questions as we go through.
Okay, and how about this? I'm echoing in my own ears. Sound okay? I'm Catherine London. I'm at UMass Medical School. I'm actually here together with Barry Dunn. Did you want to?
Sure. I'll project. But I'm John Brumbaugh from the Healthcare Authority, and wanted to just kind of set some context for Catherine's quick presentation on talking about sustainability of health in Washington and the initiatives that support that vision. And we brought Barry Dunn on board to help us develop and start to answer some key questions about how do we achieve sustainability post-SIM, post-1115, so that the structures we've established under those initiatives can live on beyond the scope of the grant. Catherine London is with UMass, working with our Barry Dunn team to help give us an idea of how other states have, what steps other states have taken in pursuit of really health innovation sustainability. We really started a conversation about, from everyone's perspective here, how do we define health innovation sustainability amongst your various sectors, stakeholder groups, and other ones. So without further ado, I'll let Catherine do this.
Also, there's a presentation here that's around. Does anyone need copies?
All right, and I'll let Steve go around with the copies. Does it sound good in the back? Is it too loud? It's very quiet. It's what? It's very echoey. Yeah, it's very echoey in my ear. So we're going to do just a very quick presentation to sort of prompt the conversation and get you thinking. And I'm sorry, we don't have projections, so we have handouts, but it's really more so that you can take this back with you. And this is very, very high level anyway. So just to start this conversation about sustainability, why are we talking about sustainability? Well, everyone talks about it all the time, but we aren't quite sure what it is. From the federal perspective, the state innovation models, the SIM grant, has some requirements where states actually have to develop a plan for sustainability and submit it to the federal government, showing how it's going to be sustained for the next 4 years. And there's not a lot of detail. This is kind of language pulled straight out of the SIM instructions. It just has to be a clearly defined plan, and there aren't details about how to do that. So I'm turning to the next page. I'm on slide 3. Every state is approaching sustainability differently. All of the SIM states are developing these sustainability plans. So I went through and just sort of pulled out some nuggets of how a few states are dealing with this. Keep in mind, that all the states are doing huge transformational approaches like Washington is. And so these slides are like one little nugget of what they're doing and clearly can't encompass everything. So that's just to keep that in mind. Arkansas is, and each of these states have developed some sustainability plans and ideas, and they're all tied to what the state itself, what their goals are for transformation or their approaches to transformation, which are different than yours. So these aren't, these aren't recommendations. This is just sort of to give you a sense of what other states are doing. Arkansas is moving to the system where large chunks of healthcare are being paid on episodes of care, which is a really different kind of a system, and so their sustainability measures are entirely around these episodes of care. Their standard definitions that they're trying to get all of the payers to use the same episodes and payment on the same episodes. And so they're measuring by episode what is the cost and the outcome by episode. And so each health plan is developing there's standard metrics across the state. Each health plan runs these metrics on all of their own providers and the episodes they're paying for, and they submit that data to the state, and the state compiles them across all the plans. So they've got this sort of standard way of measuring by episode. And with just a very general goal to reduce the cost of healthcare, reduce the growth in healthcare costs, but not anything more specific than that. But they're measuring at this episode level. And then you go to Maryland. Maryland's focus is specifically on hospitals. They've had a long history of regulating hospital costs. They're branching out to regulating all payer. They've always regulated all payers' payments to hospitals. They're broadening that, but they're still focused on hospitals. And so their measure is limiting growth in all payer hospital revenue increase. In their percentage terms and their dollar amounts, and they're very, very specific. It's very regulatory based. It's a very centralized regulatory system, and that's just the culture in Maryland. So you see that each of these are different, and you're not going to want to adopt one of them probably wholesale. But Massachusetts, where I am from, the focus entirely is on containing healthcare cost growth, and everything else comes second. We're very proud of ourselves that we have gone from being the first most expensive state in the country to the 5th over the course of doing this, so that's something. But you don't want to be like us. Massachusetts did this by establishing a target in growth of total healthcare expenditures for the state, just across the board. Healthcare expenditures can't keep growing like this. They have to stay below this benchmark, and there's a commission that sets the benchmark. It's 3.6% right now, and there's an entity that collects healthcare expenditure data from all of the private plans and the public plans, puts it out there by statewide, but also by each health system, provider system, and also by each health plan. And basically anybody who's, any of those cuts, right, by provider or by payer, if you're over 3.6%, they call you in and you have to make an improvement plan and come down. But it's very cost focused, and the clinical transformation is secondary. But basically you're left to figure it out, which is very different from here, I think. Oregon, your neighbors, have a very detailed sustainability plan. They have a sustainability work group that's very, very technical, and developed a whole plan for measuring change in cost per member per month by payer. And they're looking, separately by commercial plans and by Medicare and by Medicaid, with an idea of kind of putting them together at some point. But at this point, it's definitely in payer categories. Vermont is also moving to an all-payer system. Vermont the Green Mountain Care Board has authority to not only set targets for growth, but they actually regulate increases in hospital rates, increases in insurer premiums. Everything comes to this one board, so it's very easy for them to say, okay, we're setting the ceiling, and we're not going to prove anything over that, so figure it out. And there's a whole system that's been in place. So like Washington, Vermont started with managing chronic care, moving to patient-centered medical homes, developing chronic care teams. So they've been doing this sort of clinical changes for many, many years, and then at the end of that have sort of imposed this financial cap. But they worked on the clinical side for probably a good 10 years before they put this financial cap on it. So that's just the very, very high level, and I'm sorry for just running through this because we want to get to your ideas. So when you're thinking, so that was just a little bit of a landscape. So when you here in Washington are thinking about sustainability, you're working on this Healthier Washington innovation effort, which is really broad and far-reaching. You're working in your various communities of health. People like Molina are doing different things. We're hearing from provider groups, that everyone's doing different things. When you're thinking about sustainability, what does sustainability mean to you? And I'll put it another way. If you were, thinking, 4 or 5 years from now, we've done this whole transformation, and look, it works, and we can keep it going. What would that look like for you when you went, to report to your board or to your legislature or to whoever, and said, look, it works, and I know because, what would the answer to that be?
Probably in its broadest terms, it would mean that the level of demand in the healthcare system has been balanced by the level of funding, so that there is some stasis that occurs here. It's striking in this that MACRA replaced the sustainable growth rate in the Medicare program, yet it seems to be a predominant theme across many of the state exercises of setting some caps on sustainable growth rate as a methodology.
So there's someone over here. And then this one. And I'm sorry, I don't know any of your names.
Dan Kent from United Healthcare. Besides the financial sustainability, that we're somehow still on budget, not everybody's gone bankrupt. So they're still in the game, and the public likes the product. So in Washington, our satisfaction scores are lagging the rest of the nation, and let's get out of that hole. Let's see that this, whatever we do build, produces something that our patients like.
Thank you. Hold on one second.
In addition, we see better health outcomes, or at least no worsening in
I'm hearing better health outcomes, or at least not worse health outcomes, that you consider that a part of a sustainable system. Okay. Someone behind you. She got it already? How about up here? Sherry. I can see you.
I'm Sherry. I'm on one of the accelerator committees. And mine would be that it's sort of the intersection of the social, the environmental, and the economic systems of where they come together. So it's not just within the healthcare system, it's that health itself would be sustainable at the community level.
So we've heard a lot about that during the morning about health care versus health. So if we're looking at sustainability, and I heard, United Healthcare is focusing on, the cost of the care versus the outcomes for the healthcare system. And then we've heard about bringing in all kinds of things, the whole person, and all of the other services. How do you fit those together? And most of the states that I was just reading from, they're looking at the healthcare system, in particular, total healthcare expenditures, and what's the growth for healthcare expenditures. Where people are talking about the whole person, to what extent do we need to bring in, or would you want to bring in, social services, other spending, justice? I mean, at the full extreme, we're talking about the entire state budget and every county budget and every nonprofit budget. And then the other side is specifically healthcare services or hospital services. Where along this continuum do you measure sustainability? Just like, and right here.
I'm Andrew from the Hospital Association, and while I don't have the answers to the question, but it does, prompt me because so much of the things that require rates, in one sense, we say yes, we need to get things ultimately under control. On the other hand, we also say there are investments that need to be made, such as childhood obesity and things like that, that may pay off quite a ways later down the road. Or there are certain services that are not being provided, but if they were provided, because if they were paid for and provided, we could save money down here. And it seems unless access is a criterion and unless other kinds of things, we sometimes artificially constrain the kind of transformation in terms of service delivery changes that we're seeking. And I don't know how the states who have put these forth have been able to grapple with those things.
Sustainability, measuring it. Maybe we better look outside the box a little bit. What do we want? Sustainability. Less people on the street. More kids that graduate from high school. More kids that graduate from college. Elders that are in a safe place. This is what our state wants. This is what our nation wants. Less crime. If we look at this outside the box, whatever money we put in it is worth it.
Federico Cruz with CMAR Community Health. I want to echo on what you just said. You can't discuss the monies that go into healthcare unless you discuss the monies that go into housing and education and roads and jails and everything else. So even as the legislature has to have these kinds of intimate discussions about where am I going to put the limited number of public dollars, the rest of us have to have those exact same discussions. We can't make sense of how much we're willing to expend in health care, so we talk about what we're willing to expend in everything else.
Hi, Doug Conrad. I'm the principal investigator of the state-based evaluation here in Healthcare Washington, and the state innovation model in particular. And as I contributed to early on in a small way, but now follow what the state innovation model is trying to do, it's talked about three things: better care, better health, and lower costs. And they've got some specific measures of that. And as you've heard, some 54 to 56, on maybe a little out of date, measures in the statewide common measures. So I would suggest that one way to think about sustainability is whether in the next 2.5 years, we're able, by the end of January 2019, to make serious, measurable progress on each of those three sets of goals: the better health, the better care, and the lower cost. We've got those specifics, and I think keeping our eye on that ball and thinking about how all the various pieces contribute to that will help sustain it. And that's one thing we're going to be trying to track.
All right, hold on, because I want to push back on you a little bit. Okay, so we've got a lot of measures for better health and better outcome. How do you measure lower cost? Lower cost to whom?
Well, I
For
think
what?
it has to be a more holistic view. And again, as an evaluator, we'll have the measures that we'll have available to us. We've got Medicaid is driving some of the bus on this. There's a data request into Medicare to get information from that perspective. And as commercial health insurers, the private health insurers participate, we will have claims and encounter data for them, which we can price out or have allowed amounts depending on how we do it. So there are some specific ways to pull it together. Will we have time costs of patients? Will we have some of the social costs? No, not likely, at least not in the short term. But should we be thinking about those? So in terms of the cost, I think the driving goal has been to reduce the cost trend in state-purchased health care, principally the public employees and Medicaid, by 2% relative to the national trend. That's clearly part of what we have to measure. But I think if the pushback is we need to go beyond that, totally agree.
So do people think it is useful to start with healthcare expenditures as a measure? So, those of you who have been around for a while might remember the Clinton administration did state health expenditure accounts. And every state, just like they're the national health expenditures, if you look online, you can see those. They used to do them for every state, and you could see what your state expenditures were by service and by payer. Some states continue doing that on their own within their state. Vermont has them, Massachusetts has been developing in Maryland. Is that something that would be useful, or is that not even, because you're missing the social services, it's not even useful to just know that?
David Wertheimer from the Bill and Melinda Gates Foundation, and I think what we're hearing in the room, and what I think is really important to communicate through the messaging that comes out of this day, is that we have to think about it holistically, that we have to think about the whole person. If you start just with healthcare costs and try to contain healthcare costs, you will fail consistently if you're not addressing the full spectrum of those things that generate costs in the healthcare system, such as poor housing, poor education, lack of access to critical resources, the broken social safety net in foster care and criminal justice and transportation, et cetera. So if we start and end just with healthcare system costs, we will fail, as will all of these other states fail, to create both a healthier Washington in a way that contains costs.
Okay, so, does anyone, I'm hearing that opinion very loudly in the room, that this needs to be more holistic than healthcare expenditures. Does anyone disagree with that?
Sometimes I'm a pessimist, and while I agree with it philosophically, we're very constrained in the way we are structured socially, structured governmentally, structured in assessments. So the healthcare system within itself has a lot of waste and misapplication of stuff that we can drive out and get some control over our costs just in our own house of healthcare. But, you know, better transit, better food, better housing, solving those problems, that improves health and takes some of the burden off the healthcare system. So we'd love to have that, and how to take a few of our savings and put it out into those territories in a useful way, in an evidence-based way, is a really tough problem.
It's hard, all right, so it's difficult. We know that, what I'm hearing is Healthier Washington is about whole people. It's bigger than healthcare itself, right? It's about health. So it's something more than healthcare expenditures. And I'm going to posit that it's something less than every public expenditure. Is everyone going to agree that it's somewhere between those two extremes? And then, I don't think we're going to be able to solve in this room what you include and what you don't. But let me ask, just throw out, because we only have a few more minutes. Who do you think needs to be in the room to decide what expenditures are included in the sustainability conversation? So we're talking about what did we spend versus what happened to total expenditures? Did the cost over time continue to grow at the same rate that they were, or are we starting to bend the cost curve? I should do it this way because you guys are looking at me before. Are we starting to bend the cost curve? Are we actually reducing costs? Are we avoiding costs that we would have incurred otherwise by treating people more holistically? Those kinds of questions. So who do you think in Washington today would be best to lead this kind of an effort? And who do you think needs to be in the room to express the opinion about what needs to be included? I've got a hand up here in the front.
I actually think it's bigger than the state payers. So it's payers. 25% is patients pay themselves. Employers, which includes the state. So I think you need the people who control the money, follow the business case to make them more larger and uncontrollable.
So I could probably project well enough. Winfried Anker with Cascade Pacific Action Alliance and Choice Regional Health Network. And to answer the question, I think it has to be a very, very broad constellation of stakeholders. And I would argue that accountable communities of health to some degree probably would be a good constellation, at least to start as a conversation with, because they're supposed to engage payers and clinical providers and educational systems and many, many other stakeholders. So I would strongly argue that that would be a starting point. I'm not saying that's the only group, but I would suggest to start there.
Wait, hold the mic for a second.
Yes.
To what extent do you think that sustainability should be evaluated across the state versus within each community?
I think it's not an either or, it's an and. That would be helpful information to look across the state, but I would also argue that regions are, there are substantial differences between different regions. Look at King County, for example, which is Seattle, and a more rural-based region. There are significant differences there. So it would be at some level comparing apples and oranges, but I do think it is important to keep an eye on the entire state so that we know whether or not we're moving forward in the right direction.
Pass to the person next to you on your, I can't do less than right.
Peter Brennan from Skagit Regional Health. I still think we need some very, very clearly defined populations that we can show benefits, because we've got a pretty cynical population out there. And unless we can show some very clear benefits, I think the senior population is growing hugely, and put in some very, very good projects with silver sneakers, with walkable trails, getting together with some good dietary, how do you cook for one, how do you cook for two, things like that, that would be relatively easily measured to show that cynical population that this is working, while at the same time doing exactly what Winfried is saying. But I think we need some very clear projects that can show very demonstrable results.
Do you think it's important to show sustainability for each individual initiative or for Healthier Washington overall?
I don't think you're going to be able to show for each initiative. I think you need to find a few that could show very significant, and then it'll build some trust. The others are going to take time. Some of the things we're talking about take a lot of time. We don't have a lot of time, again, for that cynical population.
I think our table is dominating here. Janet Barron from Northwest Health Law Advocates. I just want to make sure everyone agrees here that community members, consumers, patients, whatever you call them, need to be at the table and having these discussions and making these decisions. I think, whether it's the seniors, vulnerable populations, people who feel they have not been well served by the health system, I think it's really important to get those perspectives, and sometimes they might be surprising to people in the healthcare field because they are more broad and maybe look at the interaction of different systems. So we've been trying to get some principles and some protocols around engaging community members in these discussions because it's often very hard. You've got in an ACH, you've got people who are coming to every meeting and who are being paid to come to these meetings, and it is hard for an individual community member to engage in that process. So we have some information about that if anyone's interested, but I think the sustainability discussion is a part of that, and it's an important one, because we don't want to come to the end of this and feel that people have sense that their health has deteriorated as a result of these cost controls. We also want to make sure that people who feel that they haven't been well served, for example, through access to behavioral health, have actually experienced some improvement.
Anyone else? Oh.
In this room, one is what investments or what kind of programs should changes should be implemented all personal care, and then how can we measure or what should be measuring first. Talking about investments or changes, and then measurements of what should be measured first. We do this thing like two different sessions.
And if you could hear, she's saying that there are two different conversations happening, one about investments and one about savings. And when you think about sustainability, are you thinking about both? Because it's both the financing side and the savings paying for the financing, right? I think that's one.
But, I mean,
We're 2 minutes over, okay.
Yeah, we're.
I'm Ron Vivian. I'm a citizen advocate and community volunteer, so I'm not in the profession, but I'm a consumer. And the thing that hits me is the path that many people take to poor health was based on their choices and their lifestyle during that path. And that's a little part of the holistic aspect of this. If we can keep the kid from ODing on drugs, if we can keep the adult from the diet aspects that cause them to have diabetes, etc., that have a significant impact on healthcare. Treating the health care is almost like close the barn door after the worst is all.
I think we're going to have to close because we're losing our